We have Prasanna presenting an atypical case of Ripasudil induced late onset choroidal detachment and idiosyncratic array. Go ahead.
Thank you, ma'am. Thank you, AIOCMT3 for this opportunity. So I'm going to talk on an atypical case of Ripasudil induced late CD. Early choroidal detachments are well documented after trabeculectomy and glaucoma drainage surgeries, especially due to overfiltration, and they are having an occurrence rate of 11 to 19% post-trab and 16% post-DDD. Late onset CDs are a very rare complication in our clinical setting, and previously there have been few other anti-glaucoma medications which were reported with late onset CD, whereas there has been no mention of Ripasudil as yet, and especially a spontaneous CD, and this was one of the cases of mine which I wanted to share today. A 60-year-old male came for glaucoma review, no history of any comorbidities. He's using bimetoprost for 12 years, and the visual acuity best caliber was 612 and 69 in both eyes with a near GOA, as well as he had a grade 2 cataract. So IOP was not necessarily in the low teens, which I would really wanted it to be, along with a mean deviation of severe damage in the functional aspect. So he was diagnosed as advanced primary open angle glaucoma with glaucomatous optic atrophy with right eye greater than left eye, and I wanted to go ahead and operate the right eye first with the trabeculectomy and PCOL implantation, along with an anti-glaucoma medication to bring the IOP in the left eye to low teens. So this was the post-operative 1 week picture. Blood was good, anterior chamber deep, surgical PI present, pseudophakic, BCVA was 6.6 and IOP was 13, and everything looked well as was anticipated in the first week of follow-up that we see this patient. And then come 2 months follow-up, as subjectively we are following up the patient. So the IOP, which was previously 13, has gone to 18, and in this patient the target IOP definitely would want to be in the low teens and not 18. So 13 to 18 was a concern, and Ripasudil was started 2 times a day for the right eye. And then for 2 months he was fine. You can see from post-op 2 months to 4 months. So he's been using Ripasudil for 2 months, and then when he comes here, complaints of blurred vision for since 2 weeks, and the AC is shallow, the blood is fat, IOP is 5, and this is the B scan picture. So after that picture, Ripasudil was advised to stop, and topical steroids and systemic steroids was begun, and then you can see the vision slowly improving from 6, which was actually very less. You can see it has now come to 6.9, and the IOP has recovered to 10. And this is a B scan picture which recovered within 1 week. So furthermore, the patient did not experience any recurrence of CD as the medication was stopped. So this was the complete 360-degree mosaic, as well as the B scan in before treatment, and this is after treatment. And now the patient is having a follow-up of 14 months. You can see how it settled within a week. There is a causal relationship. To prove casualty is to re-challenge, but re-challenging may not be ethical because sometimes it may fail to reproduce the event. And this patient, after 6 months of that particular late CD, the IOP was still not able to be under target, so we did put the patient on the prostaglandin analog, and that is not showing any adverse effect, and things are looking good. The discussion per se, there are 2 mechanisms in which you can have this. One is the suppression of factors, where these 3 medications are thrown to it. One is the increased uveoscleral outflow, where the ciliary body is first damaged or sensitized, and then you have the sensitized ciliary body reacting with a dramatic response. On the other hand, if it's a uveoscleral pathway, then the reduction in the level of collagen 1, 3 and 4 will be the culprit for the uveoscleral outflow overflow. In this, the idiosyncrasies could be the possible mechanism here is post-trap status. IOP was not in the low teens, and when Ripasudil was added, you had this kind of a domino effect where it really went into a low setting of IOP, which caused the low onset CD post-trabeculectomy surgery. So the direct action of Ripasudil, it's an outflow drug directly acting on the trabecular meshwork, and the ROC is actually an important downstream effector, whereas this one is a completely a reversal of it, which is an inhibitor causing a paradoxical response. And why Ripasudil was given in the post-op for the target IOP, it is very blood friendly, suppresses the subconjunctival fibrosis, and the application of it really helps us after a trabeculectomy in maintaining the IOP, and it doesn't really harm the blood. So to conclude, we report a case of a late onset CD, especially after topical Ripasudil, where it took the IOP into a low IOP hypotony with CD, especially in those settings, and it resolved on the withdrawal of this drop after conservative management. So these are my references. Thank you.
Dr. Prasanna for an interesting case. So it does happen not only with Ripasudil but with many other anti-glaucoma medications that is idiosyncratic. Did you happen to check the CDLs in this case because the bleb was avascular when you showed the picture?
Yes, ma'am. CDLs also was checked, but there was no history of any CDLs positive, as well as the bleb was also not overfiltering because on
so there was no sweating of the bleb because that could also lead to late onset hypotony sometimes.
Yeah, that was also a part of the differentials, ma'am. In the first week the bleb looked fine, but actually after that the bleb really went totally flat. So yeah.
Yeah. So in case you feel that there is something, so you can always do some compression sutures or maybe conjunctive advancement. Another thing is these patients tend to show this idiosyncratic reactions for their lives. So not only with Ripasudil, you have to be careful whenever pymatopros the patient is doing fine, but whenever you add another, just tend to monitor the patients, and these patients are refractory. You stop the medication, they'll be fine, they will come back with high pressures, you institute the drug again. So these are recurrent choroidal effusion cycle patients. So I have had a very bad experience, 5-6 cases, not with Ripasudil but other patients. They tend to come in cycles.
Though the patient is in 14-month follow-up, I was very skeptical to restart even prostaglandins because I wanted the IOP to be slightly lesser, because after 10 now slowly it's starting to come up. So I hope I'll
so
not
don't
have...
bring the pressure too low also.
Yeah.
And don't ever give Dimox.
Yes.
So sometimes
comment from Dr. Smriti has just joined us.
yeah. So Ripasudil, long term, what do you feel? Have you ever seen any honeycombing of the cornea?
Ma'am, with the Netarsudil I have seen, ma'am. With Ripasudil I have seen more of pinpoint subconjunctival hemorrhages.
So you can continue it for a longer time? You feel?
Netarsudil, whenever I see the honeycomb, I discontinue it because I don't want it to really, harm the cornea in that angle. So I have seen 2-3 cases with the Netarsudil, not with
Ripasudil. Because this is my question, like if we put them on long-term Ripasudil, then what are we headed for? So at some point again we'll have to change the drug or do something.
For me, in my armamentarium, I'm using it as a third or a fourth line medication. Especially in this scenario, why I brought it here was more bleb friendly. That was the angle that I went with Ripasudil in the post-op for this scenario.
So, in answer to that question, in bad corneas, honeycombing you see even with Ripasudil, and that can start early also. Yes, it can start early and it stops also. Yes,
Decompensated.
We had seen, we had done a study which was published in primary congenital glaucoma. We had given Netarsudil, and it led to almost 100% honeycombing. So the cases which are surgical cases where the IOP is not getting controlled, there is no filtration, so it tends to accumulate in the epithelium. So in those cases where the pressure is very high and it's not responding, in those cases which is responding, they will not show honeycombing. Honeycombing will be seen in the eyes which are not responding to your drugs with high pressures.
So one angle I would like to say, everybody may or may not agree, but in a situation like that, Ripasudil may be blamed for the idiosyncratic effect. As many drugs, we have a list of drugs. But also we need to understand there are certain eyes who do not tolerate low pressures, just like that after trap. So it may not be Ripasudil, it may be any drug that you would have started. Pressures go below 10 and you present like that. So if we tell a drug being responsible, we usually check the second time we give the threat. So that means if you restart the Ripasudil and the patient goes into this kind of a thing, then we say that blame the drug. But I would still be thinking in terms of it may be just the low pressure rather than the drug.
The Ripasudil may just be the scapegoat.
Yeah. I thought about that, ma'am. It was so tempting to restart actually.
Yeah.
That was why I put that point.
But the patient has to be explained.
The ethical
So
point of view
interesting
was
case
holding
about
back.
this thing. I have just one question on this.
Yes, ma'am.
That which you said was Ripasudil, which you explained very beautifully. That's more of a bleb-friendly drug. Having said that, with the 18 pressure, even a bleb-friendly drug, the only pressure reduction maximum it does is 3 to 4 max. So again, I would have personally favored beta blocker or something which causes an aqueous suppression vis-a-vis something which causes a more of an aqueous outflow increase. But very beautifully presented. And one take on it, supposing this recurrent CD happens, would we give a long-term cycloplegics for these patients? Message to take home? because how to ensure that the next time, like this is a cycle, they'll go on high pressure, then again don't need something, then again they'll go into that.
Yeah, at least an intermediate term cycloplegic is what I would prefer in these patients, at least for a month or two, if not long. If it is really
I
a
would say
bad,
once a week or something, every Sunday you give some cycloplegic and just manage it like that. If it is a repeated thing, not once, not for the one time. If it becomes okay, and I would, again, this is again a personal anecdotal experience not published, go for a needling, plain needling, just not with mitomycin. If it's an early bleb failure, just try a plain needling with saline and just break the nascent fibrotic bands rather than going for a drug. Because all drugs do have issues. So beautiful.
Thank you.
And very good discussion. It's good that you're having these discussions. It's a good learning exercise.